Okay, so hello everyone out there in the wide world. On behalf of the editorial team of the Journal of Philosophy of Medicine, welcome to our panel discussion, which is titled Philosophy of Medicine on COVID-19. I'm Jonathan Fuller, a faculty member at the University of Pittsburgh, and along with Alex Broadbent and Maya Goldenberg, who are with us today, a member of the editorial team of the Journal of Philosophy of Medicine, which is a new open access journal generously supported by the Center for Philosophy of Science at the University of Pittsburgh, as well as the Faculty of Humanities at the University of Johannesburg. And today's panel is brought to you by the journal, as well as the Institute for Future of Knowledge at the University of Johannesburg. So the COVID-19 pandemic has challenged the way we think about evidence, ethics, politics, decision-making, and it's far from over. So we thought at the journal that this would be a good time to bring together philosophers thinking about public health and medicine, as well as clinicians and public health experts to think through some of the problems. I've structured the conversation today around 6 topics with an associated prompt, and the topics are normal science versus fast science and public health crisis, modeling and evidence in public health, science and uncertainty and decision-making, expertise and science communication, the relationship between public health and the publics, and finally, pandemics and population health. And I'd like to send a special thanks to several other journals for helping me to construct some of these questions. The journals Global Epidemiology, the Journal of Epidemiology and Community Health, and the Journal of Evaluation in Clinical Practice. So what we'll do is we'll have about an hour of discussion based on some topics and prompts, and then 30 minutes discussion based on questions submitted by the audience. So if you do have a question, please type it into the Q&A box on Zoom, and I'll either read out the question verbatim or paraphrase it, or maybe synthesize some questions if there are a few on the same theme. And we'll try to get to as many questions as possible, but we have a good number of participants with us today, so apologies in advance if we don't get to yours. So before we start, I'll just now introduce all 5 of our panelists, and then we'll launch right into discussion. So we're very privileged to have with us today 5 esteemed panelists. Trisha Greenhalgh, Professor of Primary Care Health Sciences at the University of Oxford, Ross Upshur, Professor of Clinical Public Health at the University of Toronto, Alex Broadbent, Director of the Institute for the Future of Knowledge at the University of Johannesburg, Maya Goldenberg, Associate Professor of Philosophy at the University of Guelph, and Sang-Wook, Director of the HY Center for the Ethics, Law, and Policy of Science and Technology at Hanyang University. So hello to all of you, and thanks for joining me. Okay, so the first thing I want to talk about is normal science and fast science and public health crisis. So here is a prompt to get us started thinking about this topic. So in addition to the viral pandemic, over the past year and a half, the world has seen an epidemic of questionable science practices. For instance, poorly designed and coordinated studies, pseudo-experts, and science by press release or preprint, as well as fetishized treatments such as hydroxychloroquine. At the same time, alongside this, we've seen science success stories, timely and effective vaccines, large collaborative platform clinical trials. Then again, there have been stark scientific and policy disagreements, as well as reversals of policy and opinion. So amidst all this, a couple of narratives have emerged, and these are, I see as competing narratives to make sense of what's going on. The first narrative that I've heard is that the pandemic has simply pulled back the curtain on what we might consider to be normal science. So in normal times, science and public health are messy and uncertain. Disagreement is common. Science has its successes, but also its failures. And there's nothing particularly unusual going on here. But I think as many of us have heard, there's another narrative that these phenomena we've seen in the pandemic are characteristic of something different, fast science or public health crisis, in which the usual norms of science and public health are, at least to some extent, disrupted. So I'm interested in what story we should tell, which of these narratives, if either or both are helpful, and what ways has COVID-19 science and decision-making been normal or abnormal? What can this teach us about the nature of science and public health? And maybe I'll add, should there be norms for science that differ between crisis and calm? So this question I wanted to throw out to the group. Anybody's welcome to raise their hand and start us off. Trish.
Yeah, I'm not very good at raising a virtual hand, so that's me raising my hand. Yeah, no, great introduction, John. This is a really fascinating question, isn't it? And I'm a great lover of hard cases, hard examples in philosophy, because you can go round and round if you don't have those. And the one I started cutting my pandemic teeth on was face masks. So why don't we just throw that one in? It seems to me that it wasn't so much, or it wasn't the fast science versus slow science. And we need to ask, why is science normally slow? And I think one of the reasons with medical science being slow is that what medical science often does is it tests new drugs, and new drugs need a lot of caution. Because as we all know from those examples like TGM-1412, where a new drug was given to people and really ghastly things happened. So if you're putting poisons into people's bodies, dreadful harms can happen, and it's entirely appropriate to be cautious. What we had with face masks was a lot of arguing about whether they were effective, whether they're not effective, and extreme caution being argued by scientists who said, no, you're jumping the gun, we haven't got enough evidence yet, we must wait, we must have our randomized controlled trials. But actually, there's this thing called the precautionary principle, where it says, look, the chances of serious harm here are tiny. It's a piece of cloth. It's like your t-shirt. This is really not a very harmful thing. It might be very inconvenient and all the symbolic issues, but the potential benefits were massive. We could have prevented a lot of deaths, but science, broadly speaking, said, no, we must exercise caution, because that is good science. And one of the things I remember at quite a personal level was getting emails from senior scientists in my own university saying, you're being very slapdash here. But actually the precautionary principle was entirely appropriate, because the balance of benefits and harms was very different for cloth face masks to what it was for a new drug. And in philosophy, I mean, you guys are philosophers. I'm not really a philosopher. I'm a sort of amateur philosopher, but I've heard this presented as the problem of inductive risk. In other words, the hypothesis that you are assuming is correct may not be correct, but you kind of know that. What you're saying is it doesn't matter if it's not correct, or the downside is. So that's my hard case to throw into that.
Yeah, thanks very much, Trish, for getting us started. Ross is jumping to get in here.
Yeah, no, so
Ross.
I think we have the potential risk of spending the entire panel on this particular prompt and question because it's so fascinating. So just to pick up, I think, we might want to circle back to notions of inductive risk, which I think is a really important contribution that philosophy of science in particular can contribute to policy discussions and debates. But on the fast science issue, it's really fascinating to look. There's one of my favorite journals is called Scientometrics, and they've done some studies on the fast science phenomenon, and it's not uniform across the disciplines and across the world where this rapidity has actually shown up. So certain sectors have had a huge, and I was just at the R&D blueprint meeting for the WHO. I had to step out to come into this, and they presented where the investments were, like where the money's going, where the speed, quote unquote, and acceleration is happening. And it's really remarkable to see the heterogeneity of funding opportunities. So this perception of things going fast might be a phenomenon of where your head is at. Like if you're following Twitter, if you're following certain news media, it seems like there's this acceleration. But on certain really critical interfaces, particularly there's one aspect of the R&D blueprint, which is around One Health and origins and emergence of the viruses, that hasn't been fast and hasn't got a lot of investment. Secondly, there's this notion of the ACT Accelerator, which is supposed to get $48 billion to move science and into the field to implement. And Trish will be interested in this. The health systems, like the primary care public health pillar, has gotten no money. So as critical thinkers, we might want to stand back and ask, where has this acceleration taken place? Why is it that hydroxychloroquine got like 5,000 underpowered studies and all of this attention? But we want to step back and take an all things considered look at how science is performed across all of the relevant questions that require attention. And so some have been fast and some have been actually not looked at all. And sometimes I think that from certain perspectives, the entire pandemic is occurring either in the spike protein or in the intensive care unit, and it seems to neglect vast swaths of human experience that I think need attention. So I'll stop there.
Maya?
But back to your question about what's the best characterization, whether it's normal science, whether it's fast science, the answer is actually everything. And there's even a few more sciences. There's crisis science, there's bad science, there's good science. All of those things are happening here. And when people try to characterize the research trajectory around COVID, they're pointing to certain things. So when people say, well, what we have here is normal science, they're trying to tell the publics, in most cases, they're trying to tell the publics to calm down about the fact that directives coming from public health change at times, because that's normal science after all. And to think that science is a set of static facts is not helpful. Same with the journalists who are reporting on preprints, don't do that. At the same time, calling it fast science is pointing to the crisis situation that we're in, and that is in some ways improving scientific outcomes and harming it at the same time. So Trish pointed to some disagreements, philosophical disagreements about what counts as enough evidence for masking in the community. And that's kind of an old debate in public health, whether you need evidence-based public health or whether you need more pragmatic evidence based on what you got, what you can get, and the need to act. We've also seen the other direction where the standards for trying new experimental therapies on patients have been dangerously low. So that's where evidence-based medicine seems to have left. And that's of course exactly where we need the more careful trials. So all of those things are happening at the same time. What we should be doing is, instead of trying to label it as a certain type of science in action, we have to sort of draw out what are the things that worked well. For example, the collective effort to create new vaccines in a year was an amazing effort. Then other things didn't work well, like stuffing those new vaccines under intellectual property protections is not helping the global health effort. So I'd like to see more about deciphering what went well and what didn't, so we can have lessons learned.
Thank you. And Alex?
Yeah, I guess I've got three things to say. The first thing is I think masks are actually unusual in the sense that the precautionary principle applies to them because they are obviously low risk. That cannot be said for many non-pharmaceutical interventions, which have obvious detriments. And in fact, precautionary principle was used as a reason to implement them. So the precautionary principle can work both for fast science and to slow science down. I just want to make that point. In many cases, what we've seen is actually, the racing of results and the using of results prior to their being published and so forth. And that brings to the second thing I want to say, which is that many people involved in science in these areas actually want to influence policy. So there is it is why they are doing this, that you're only really in public health because you want to influence policy. It's not like philosophy where you might want to influence policy, but you might not. I think, certainly the people I don't know in public health, obviously that's what they're doing it for. And I think that's, creates an interesting situation where there's a kind of desire to separate politics and science, and yet that's not actually the reality of why people are interested in the first place. That's not a criticism. It's just that it's interesting that the picture that one might have of science and politics and the relationship between them is perhaps too simplistic. And it leads to the third issue, which is that the attempt to enforce that by a strong insistence on expertise, which in one way is reasonable, where you have cranks and so forth. But on the other hand is is quite damaging, I think, because it means that you can't, and we were discussing this in the conference we had just now. It's very difficult for people to bring in perspectives that aren't backed by a clear scientific discipline. So if in particular you want to bring in, you know, social science type perspectives, you want to raise contextual knowledge about a particular domain, a particular area, a particular region, you know, unless you have an evidence base, you get asked, where's your evidence? What, you know, and what's your expertise? And if you are not a relevant medical scientific expert, and in particular, epidemiology is a discipline in which people do come to it from very different backgrounds, a little like they do to philosophy, interestingly. Then you risk being called a charlatan simply because people don't agree with you, and that's I don't think that's a situation that's beneficial from any perspective in the long term.
Well, I wanna Sang-Wook, go ahead.
Yeah, I just want to mention one point, which is related to the issue of range of acceptable evidence. What I'm saying is this: in the case of normal science, in its original sense of Thomas Kuhn, the criteria of acceptable evidence to decide whether certain actions like a face mask is effective or not is entirely determined by the internal criteria of expert community designated by, you know, current academic field. But in the case of emergent case situation like this COVID situation, you may want to consider this narrow range of evidence and enlarge them into the more historical or sociological evidence. For instance, in the area where this face mask is culturally very familiar because they use for the protection from the pollen allergy, or whenever you have a cold, if you have a custom of wearing this face mask. I mean, I'm in that region of the world. In our countries and some other countries have this kind of cultural heritage, then it's much easier to accumulate this historical evidence that, although it's not scientific evidence, it's not collected in a scientific way, and it's not dealt with a proper statistical method, but still you have a experience of effectiveness of face mask in some other related disease. Then it's easier for us to accept that the effectiveness of facial mask without actually having a full consensus among the experts in epidemiology or some other areas. So I think it's this range of acceptable evidence can be expanded over the conventional understanding of normal science, and it can be instrumental in mediating between your original question, between the fast science and the slow normal science. And that's my opinion. Thank you.
Thanks very much. And Trish, back to you.
So sorry, unmute. Just to come back, I mean, it's great to have Kuhn brought in fairly near the beginning of this talk. And yes, the whole idea of what counts as quality in science is defined by a group of scientists. What are the problems? How should we investigate those problems? What counts as quality? What are the theories? What are the appropriate methods? And we've seen that play out very, very dramatically with what I've heard called epistemological trespassing by the evidence-based medicine community, saying, hang on, we need a randomized controlled trial. The RCTs haven't proved, and you know, they've shown this, that, and the other. Are we really looking for RCTs here? Now, we could carry on talking about Kuhn, but I think it'd be much more interesting to talk about Bourdieu, because as I understand it, Bourdieu was quite interested in the link between these scientific paradigms, or fields, as he called them, subfields, and power, political power. And I think one of the things that we might look at is how politically well placed different scientific subfields were to present their arguments. And one version, one narrative of what went on in the pandemic was that people with a hospital medicine background, trained in evidence-based medicine, actually, and also primary care background, but very, very sold on experimental evidence from RCTs, were in politically powerful positions within, for example, the World Health Organization, within national policy bodies, and imposed a particular version of the hierarchy of evidence on political and policy decision-making.
Yes, thanks for that, Trish. So I think we've basically transitioned into the next topic that I wanted to discuss, which is evidence, evidence-based medicine, and how we think about these things across the sciences. And I'll get to you. I know you had your hand up, Ross, so we'll get to you in just a moment. So, you know, as you alluded, Trish, you know, I think there have been a couple of different threads that have run through discourse in the pandemic. So on the one hand, people say we need more evidence-based medicine. Look at all these low-powered cruddy trials. And on the other hand, we saw evidence-based medicine having some influence in public health decision-making around, let's say, face masks, and maybe even evidence-based medicine types influencing some of the debate around aerosol transmission versus droplet transmission, fomite transmission of SARS-CoV-2. So different sciences have different ways they look at evidence, different standards, maybe different heuristics. And people have questioned whether or not evidence-based medicine's standards, its preferred kinds of evidence, its ways of synthesizing evidence or doing reviews of the evidence base are appropriate outside the context of outside those contexts in which they're normally applied. So drugs, for instance, pharmaceutical interventions. So, you know, do we need more evidence-based medicine in the pandemic? Do we need less? Are there contexts in which we need more and contexts in which we need less evidence-based medicine? And how should we think about evidence in an area like public health, in which the evidence base is quite varied and diverse, unlike the evidence base perhaps sometimes in other areas of medicine and public health, where we might have 5 high-quality, large randomized trials? Ross.
Yeah, so I've sort of seen the past 30 years of my career flash before my eyes during this pandemic, and it's interesting that people suddenly got interested in public health, because it's typically been sort of one of the least popular areas in the whole biomedical sciences. So I think we do need to start thinking differently, and it's been remarkable at different tables where you get engineers and vaccinologists and immunologists and basic science people, implementation science, trialists, all sort of, it's like the Tower of Babel. It's all these different languages of science and inference. So we might want to step back. I've been toying with this notion of pan-inference. What is the way that we can look at forms of logic and reasoning that may assist us? And John, it won't surprise you, because we've had many discussions over the years on this notion of defeasible reasoning schemes, and how defeasibility is a central feature of evidence. If it isn't defeasible, it isn't evidence. And if it's defeasible, it means that it's subject to modification, change, and varied interpretations. So if you start with the problem with evidence-based medicine, having studied at the school that created it with the people who created it before it was called evidence-based medicine, is they actually never sat down and thought, what is this thing that we're calling evidence other than the property of certain methodologies? And it's an ongoing stress and strain, and everybody wants to be evidence-based, and it's a completely vacuous and meaningless term because the only thing it is something that isn't whimsical, arbitrary, or just because I say so. So like the number of times in which it's like the greatest brand demanding exercise in intellectual history, because it just gives a safe space for people to say something aspirational, or and I think to Trisha's point, as a way of sort of monitoring or mobilizing the power of their position. So I think the first step is to demystify evidence and to stop saying things are evidence-based, because even the very idea of basing your decisions on something that's defeasible means that you're basing it on something that's shifting. And this is what's making people crazy, is that they have this kind of notion of science producing certitude, which it doesn't, and not appreciating that it's going to be a dynamic change, and particularly in sort of high uncertainty situations like we have in COVID about a year ago, there is going to be no evidence to guide your decision on. And that's where I think this notion of pan-inference needs to look at dynamics of scientific accumulation, particularly when you throw billions and billions of dollars to the scientific process to sort of harness uncertainty. But we need to sort of start thinking about what that would look like, where we need to be more precautionary and why, and where we can transition into sort of thinking about uncertainty in different ways. But the other big issue is the communication of this, because I think it's been a complete failure in many ways. And now we're having all this, there's a new language, which is abundance of caution, which is undergirding decision-making. So I'm not sure how abundance of caution relates to precaution, but it seems that the discourse is becoming even more confused as time goes by in certain areas. So I think, one, demystify evidence by not saying that things are evidence-based when they quite clearly aren't. Take away the power of that phrase as something that is meaningful, and then then think about the structures of reasoning that we need to put in place to help us move forward, which would be this kind of transdisciplinary way of thinking.
Alex, I'll move to you.
I agree that within the sort of internecine debates about evidence-based medicine, the term has become meaningless. But in a sense, the pandemic has actually reminded me of how important it actually is to insist on evidence, because my view is that there has been a shortage of evidence for the effectiveness of measures, particularly as they apply to lower middle-income countries. There were measures that were adopted or recommended by the World Health Organization and adopted in wealthy countries, adopted in other countries, largely on a copycat basis. And there was no evidence that they would work, but also no good reason to think they would work. So no evidence in the broadest sense, no warrant. If you have a situation where, you have significant overcrowding, less than half of your population, less than half of households have piped water, people have to leave the household to get food and so forth, then telling them to stop working and stay home, it's just prima facie not going to reduce social contact by 75%, which was the amount you needed to reduce social contact in the model that motivated that policy as it was applied in the country, in England and Europe and so forth. This was then adopted, I'm talking about, of course, the model published by Imperial College London in March of 2020. That stuff is then done in Africa or not done in many cases. And there's just no good reason to think that it is going to work for you. It's this will it work for you thing. So, and at the same time, there was no evidence at all to quantify the impact that would have on people's livelihoods and health and just general livability of life. And so, I'm bringing this sort of global South perspective to it, but I think that there was a real lack of evidence in the broad sense about whether any of this would work and whether in particular it would work in settings other than, Geneva or something where the World Health Organization, presumably numbers of them are. I think it's important to variegate it by context. But in that sense, I do think there has been really a gross lack of evidence. And I also am not seeing the efforts to assess effectiveness anywhere in the world of things that were done, but particularly in those contexts. either to assess the effects the effects of a regulation on behavior, because obviously that's one place where it can go wrong, or to assess how the actual behaviors then led to changes in transmission rates.
Sang-Wook?
Yeah, okay. Can you hear me? I accept, I agree with Alex that lack of evidence is a great problem, but I wonder whether we should consider another problem, which is diversity of evidence from different areas, given the fact that we have a disunity of science. For instance, we had a situation in South Korea a few months ago when there is uncertainties about the future progression of COVID-19. There is a different opinion came from the different scientific community, epidemiologists and microbiologists and clinical doctors. And within their community, there is a more or less consensus based on their criteria of evidence, and they have some evidence for their conclusion. But when evidence from different area compare with other evidence from the different area, then because of the incommensurability of meta-evaluating evidence from diverse different academic disciplines, it was very difficult to come up with uniquely convincing conclusion over our action to take based on the evidence. So I don't have any solution to this, but this evidence from incommensurate different academic discipline should be also considered in the case of this emergency.
Trish?
Yeah, just to again follow on from that, the whole business of the types of evidence that we want to include. I read a fantastic paper, which I'm going to dig out and put a link in chat, by, I think it was David Ogilvy and colleagues. I'm pretty sure he was lead author, but I'll put it in chat, about the difference between a kind of narrow EBM type Cochrane meta-analysis on the one hand, and a broader, rich narrative review of the evidence on the other. And they use this wonderful metaphor of the brick wall versus the dry stone wall. Now, if you're building a brick wall, it's really important that all the bricks are the same size and the same color. And actually that is precisely what you have to do if you're doing a meta-analysis of RCTs. They've all got to have the same research question, the same endpoints, broadly the same population. And you know, you talk about lumpers and splitters and things like that. Now, up in the north of England, where it's all, there's lots of kind of hills and wavy parts of England, and you have to build these walls with these stones because the fields are not very oblong. They're all different shapes. And what you do is you have these stones and you pick different stones of different shapes to fill the holes, and you might have a hole that's a really strange shape, so you have to find the right stone. And what Ogilvy et al. Talk about in relation, I think, to the pandemic, or maybe just before the pandemic, they were writing this. Sometimes public health evidence needs a dry stone wall rather than a brick wall. And I absolutely love that metaphor for the kinds of evidence. And I think if you give me a bit of time later on to talk about aerosol science, I'll give you some examples of a dry stone wall there. But I just thought it'd be good to bring the metaphor in. Anyway, I'm going to go quiet because I'm going to look for the paper now.
Thanks, Trish. Yeah, we'll come back to you. I am interested in hearing a bit more about that particular issue, aerosol transmission. But I think I want to move to a related topic. It's hard to talk about evidence without talking about decision-making, because public health isn't a basic science in which we're trying to ponder the nature of the natural world. It's a context in which evidence is primarily used for action. So I have a short prompt I'll read, and then we'll hear your thoughts. So by now we've all heard about groups and individuals following the science, or sometimes not, with their actions. But as I think we'd all accept, decision-making in the context of a novel pandemic virus is very complicated. Complicated not only by shifting scientific understanding, but also by ethical conflict and political conflict, leading to epistemic as well as moral uncertainties, which undermine the follow the science slogan. Uncertainties are experienced, for example, by governments and public health deliberators modeling the future of the epidemic, or balancing the needs and safety of school children with those of vulnerable older adults, by healthcare workers devising policies on the use of scarce resources, or providing care for patients suffering from what initially was an unfamiliar disease, and by all of us as individuals who have to weigh the risks of our personal actions for ourselves and others. And these challenges have been acutely felt by many and continue to be experienced today, especially in countries such as India, in which the pandemic is out of control. So what strategies or principles should we use to navigate such uncertainty and to manage it? And when I was thinking about this topic, Ross, I was also thinking about you and the things you've done throughout several pandemics. So you've worn many hats as a clinician, as an advisor, as a scientist. You've been there for SARS-1 and now SARS-CoV-2. And so you've faced uncertainty in the clinic, you face it as a scientist, and you've faced it as an advisor to various bodies, such as the World Health Organization. So how do you think about uncertainty? How has your background, maybe in logic and philosophy, helped you to think about it? And what's special about public health decision-making as well, that perhaps forces you to think a bit differently than you do when you're faced with a single patient in the clinic in times outside of public health crisis?
Yeah, those are excellent and question. How long do I have to answer? No, I'm just kidding. So as I said, I've seen my entire career flash before my eyes. So it's fascinating because this pandemic is actually probably the truest pandemic. I don't think there's a person on this planet that hasn't been affected in one way or another, as my colleague Solly Benatar pointed out. So it's challenged us on multiple different levels. So one of the things where we're not prepared, and this is where I think a philosophical background comes in very important, is that you're not, most of us speciate into our various forms of philosophy, but if you do an undergraduate degree to get an honors degree in philosophy, you have to do at least one class in ethics and one class in logic. So you know that there are these discourses and concepts that have a history and a relationship to each other. So the great failure here, and I've been working at trying to do another presentation where I'm looking at different visual cortexes, so you can tell the audience that I'm trying to speak to, because I think that there's lesions in our collective cortex that have impaired our capacity to see the problem in a fulsome way. The sense that in certain tables, value discourse gets completely cut off. There's like a hemianopsia, that these kind of problems are purely technical and they don't have a value component to them. When actually what I've learned over the years is that they're mutually co-constitutive, particularly in public health. Public health decision-making, back to Trisha's earlier point about precautionary reasoning, so public health, true public health and public health practitioners, if I'm a medical officer of health, I have a strong mission for health protection. That is my mandate. So my mandate as a clinician is to look after the well-being of the patient in front of me. And a lot of the inductive risk issues are sort of built into that relationship. As a medical officer of health, and I played this role during SARS-1 in Toronto, I have a health protection mandate, which means that it's my obligation, it's my duty and responsibility to prevent transmission of infection by whatever means I need to do. And so that's where, when you look at the commissions of inquiry that occurred after SARS-1 in Toronto, the precautionary principle played a huge role, particularly in the Campbell Commission. It also played a massive role in the Creever Commission looking at the tainted blood scandal. So one of the jokes I have with my students is I'm going to do a course on commissions of inquiry in Canada because they are comprehensive. They have massive recommendations. And each one of our failings within this current pandemic has been foreshadowed and sketched out in those commissions of inquiry. So how do we deal with uncertainty? One is we stop forgetting. So I'm also in pursuit, like the report I'm going to sound like a raving mad person. I'm sorry, but this gets me worked up. The report that came out yesterday on the pandemic by Clark and Sirleaf, what do they say? It's a wake-up call. We need to learn lessons. We have had those same cliches used after Ebola, after H1N1, and after SARS-1. So how do we deal with uncertainty if we don't learn from our own experiences and carry it forward? Because the structural issues that we faced in COVID-19, all of those elements were there. We should have been better prepared. So we could have closed. So yeah, it's an unknown virus. We're going to need to act precautionarily, take measures while we settle things out. But all of the elements of what we needed to know and needed to do were there. And all of the warnings have been existing since for decades. So the fact that we had such a dysfunctional response speaks to our collective ability to act together. But I think going back to where I started, we just don't see the problem in its entirety because we have partitioned off the way of thinking it into all these little independent departments. Back to what Sang-Wook was saying, we've got all these little epistemic cultures that don't talk to each other. They don't adjudicate evidence the same way. And then when you have a public health emergency, the poor public health physicians are sitting there trying to say, well, how do we adjudicate all of this? Well, if you have a way of thinking that combines values and epistemology, then you're not going to be afraid to say we are making decisions in this direction because we're trying to uphold and protect certain values. The other important thing that we fail to do is articulate clear goals. And so goals are helpful to the sense. I became a closet teleologist. If you're figuring out what you're trying to do, then you can mobilize resources and prioritize towards those actions. But we've completely shifted the goalposts at every state, and every jurisdiction has done this. So another interesting sort of piece of research we're involved in is actually looking at and interviewing science advisors to see about their experience of providing advice and how it's been taken up and how they think the process should go. So there's some really important empirical work to go on as well. I'm sorry that was incredibly scattered and incoherent, but thank you for the opportunity. So there are lots of ways to deal with this, but philosophy is key.
Anyone would like to follow that? Hard to do. Okay, why don't we talk a bit about expertise in science communication? So there have been a number of controversies that have inevitably filtered up into the world of media and mass attention. So here are some problems that we faced, and I want your answers to how we should think about them and deal with them as a community. So there have been a number of challenges related to science communication and scientific expertise. We've heard about these misinformation and disinformation, different channels giving us different information, sometimes inconsistent, scientific and policy disagreements, even among members of the scientific and healthcare community. And here we can point to examples like lockdown, as well as the mode of transmission of SARS-CoV-2, droplet fomite contact versus aerosol. And people with diverse backgrounds treading into public health science, which gets at something we've been talking about already, and perhaps, to use Trisha's word, trespassing in certain circumstances. And some of the problems that arise from this might be that it could undermine clear and univocal public health messaging, but it also raises questions like who are the real experts? What do we do when there's no clear consensus, or when it's not clear what the consensus is because the messaging is so mixed and there are many voices clamoring? And what ethical responsibilities do various actors have? So what ethical responsibilities do scientists have as individuals who might believe who might have their own preferred hypothesis that could push against the grain? What responsibilities do they have in communicating with the public, including their responsibilities to a scientific consensus that they might not agree with, even when it's there? So I actually thought we could start with Sang-Wook, you for this question, because you've thought quite a bit about ethics and technology, including scientific research on new technologies. And these days, a lot of these controversies are around vaccines. So we face challenges such as misinformation and disinformation about vaccines, as well as challenges around how to communicate with the public around vaccine safety, including when we learn of a new potential adverse event related to a vaccine as it rolls out on a mass scale. So from your perspective, how should we think about these problems ethically and drawing in perspectives from science and technology studies in other areas?
Wow, this is a huge topic. I think we start with two different scenarios of society where the level of public trust in scientific expertise is high or low. I mean, when general public, more or less confident that scientific expertise is important, especially with respect to these public health issues. That's the case in South Korea. Still, we have a problem because, as many people mentioned already, the different expertise belonging to the different disciplines might come up with different opinions especially when there is a large uncertainties about the nature of the epidemic and the effectiveness of our measures. When general public has a confidence in the scientific expertise in the past, they tend to want to hear the definite answer for the nature of epidemic and the effective measure of epidemic, rather than different voices from the different experts from different academic disciplines. So when they hear these different voices, depending on solidly based on their own expertise in their own disciplines, public tend to go the other extreme, saying that, okay, even expert doesn't know very well about these things. There are so much uncertainties in this problem. So, this is basically personal decision. We don't have any kind of reliable, objective, the evidence or the conclusion about this. I mean, every individual has to decide in its own way. That's a danger of, even when the public trust in science is high, this kind of uncertainties and the epidemics goes on, still we have this kind of danger. And secondly, when public trust in scientific expertise is not that high, I mean, there are some areas in the world where people have a more strong epistemic value in the religious decisions or some other areas of personal belief system. And then there is still larger problems, because then even when there is a consensus among expertise about the effective action to take, many people won't listen to this epistemically sound advice, but go for their own way of belief system. And this is huge challenge to persuade them to accept this kind of evidence-based expertise. I think my answer, I mean, the temporary answer to your original question is actually given by Lo's final remarks in your really pertinent the talking, which is this. I think in the case of great uncertainties, the scientific expertise should adopt the attitude of putting forward their value judgment with their evidence-based expertise simultaneously when they talk to the general public. So they shouldn't say that, this is definite answer, this is scientific result, so you should just accept it, because general public won't buy this kind of pseudo confidence. But on the other hand, they shouldn't just say that, oh, there are so many other things we have to consider. We are not uncertain, or we are not certain about this conclusion. We still have a much more research to be done in order to give you some definite answer. I mean, that's kind of a very risky scenario for public to lose their faith in scientific knowledge. I think that the more fruitful way of approaching this problem is, okay, there are large uncertainties in this area, but upon the evidence we have collected up to this point, and because the human lives is more important than the epistemic uncertainties, I personally believe we have to take this action. It is followable it is a high risk of responsibility, but I think that's the way of scientific expertise to be used in this case of emergency situation.
Thank you, Maya.
I'd like to bring in the good work that's done in science and technology studies and science, technology, and policy studies, which I think is helpful, first of all, to not frame this question about what are individual publics supposed to do when they hear this or that, and also what are the individual scientists supposed to do when they're communicating with the public, but instead to think about it much more socially, much more broadly. So we've already alluded to this a few times, that there are numerous experts that are informing what we know about COVID-19, and just try to think that we can whittle it down to epidemiological models is false, or children health experts is going to somehow answer these things. Not at all. So when scientists speak to the public, they should certainly be acknowledging that they are speaking to a certain slice of expertise, and because of that, they come in with a certain perspective. Not to say that the perspective is biased, but it is narrowed into one area of research and knowledge. Similarly, this is going to endorse what Ross said about the need for a broad liberal arts education. We need more ability to think through how we bring these things together. And I think actually STS does that quite well. They usually do. It's usually retrospective case studies, but they show the number of players that are contributing to, let's say, a decision about whether to ban a toxic chemical or something like that. It's never one scientist. We also need a lot of input from the public, because they are stakeholders in public health emergencies, and we need some kind of democratic framework for bringing in the various perspectives, including public perspectives.
Alex, would you like to follow up?
Yeah, I mean, I think the way that expertise has been talked about during this pandemic has been one of the most troubling things about it. I mean, in my view, there are no experts on COVID-19. There are experts on different aspects of it. There's virologists and there are epidemiologists, but you can't, it's not like these are the experts on, this is a new situation. And in a sense, that's true for any new situation. Because there's always an active synthesis, and whenever you're trying to predict what's going to happen in all things considered way, you've got to have different, you've got to consider everything, and there isn't an expert in everything. So I mean, in a way, that's been extremely damaging, and perhaps it's sort of it must be resonant with the climate science debates, where the language has carried over, and skepticism and deniers and stuff. And I'm sure that political context is part of why that is the way the issue was framed. When you have, because there clearly are people who are just behaving in a way that's outlandish and just saying nobody can tell me anything. I believe what's in front of me, although perhaps not even that. And then because those are the same people who are also saying that about climate, you end up with this idea that you've got to listen to the experts. But that is a problem when there aren't any actual experts on the exact question. You've still got to perform some critical task. And related to that, I think one of the most unpleasant things about this has been to see the way scientists have treated each other when they disagree. I mean, I've read Thomas Kuhn and so forth, and I know in theory that's how it works, but some of the Great Barrington Declaration is an example of this. Regardless of whether they're right or not, or whether you agree with them, they're obviously serious people, and they are not taking a manifestly unreasonable position. But there's the treatment of those people, the attempt to discredit them in some cases, is it's hard to see how that's helpful. From the point of view of anything like a well-ordered science or a well-ordered debate. And the third thing I wanted to say related to that is that it's question. I wonder whether we really actually want trust in science. I mean, the whole attraction of science is that you don't have to trust it, and it doesn't rely on appeal to authority. That's science's claim to fame over really any other knowledge system. That's the point. So obviously, if you don't know about something and somebody else does, you'll need to get the knowledge. But the idea that trusting in science, and trusting in particular in medical science, is something we actually want to encourage seems to me wrong. And I agree with what Maya said about this. I mean, and you don't have to be dismissive by saying you don't want to trust, but if you just, if the public is presented with this choice between trust and not trust, it's hard to blame them for not trusting, because who wants, I mean, it's not scientific to just trust. So there's a really weird dialectic going on in that debate. And I would actually advocate for less trust, but more critical thinking, which is another way, I suppose, of saying more education without being too patronizing about that.
Trish.
Yeah, I agree with Alex, but I just want to come back to some of the things that Maya was talking about, because, and maybe take those forward a bit more. I totally agree that this, I know it's been framed initially as science communication to the public, but I think it's much more about science deliberation with the public. And that in itself calls for a bit of philosophical unpacking. It is about uncertainty. It is about thinking which theoretical lens is relevant and appropriate here, which moral lens is relevant and appropriate here, and collective deliberation on what is the most appropriate way of skinning the cat, for want of a better metaphor, is actually a really important thing. I'm thinking partly about some of the work that Andrew van der Ven has done around pragmatism, drawing, of course, on people like John Dewey, where if you're taking a philosophically pragmatist approach to something, things do not become clear and relevant until you have really engaged with the concrete situation at hand. And the people who can help you engage with that are going to be patients and the public, and et cetera, et cetera. I'm going on later on today to talk to people in India, and they're going to tell me which aspects of ventilation policy are actually doable in the actual apartment blocks they live in, you know, that kind of thing. But as one engages with the concrete situation, with its constraints and particularities, some philosophical lenses, some theoretical lenses just fade into the background as completely irrelevant, and others become salient. So I think, I know pragmatism is not going to give us all the answers, but I think the fitting that in with the need for local and also, you know, national, international deliberation it's a responsibility that we have. So the idea that there is this science that people can trust, I agree with Alex. Now, that's not the way to do it, I think.
Ross?
Yeah, just to pick up on points made by Trisha and Maya and Alex about the need for greater public engagement in deliberations and discussions. So, for example, when we were trying to work on the triage policy in our current province under exigent situation, right? So they needed something because it looked like we were going to be flooded, but we didn't actually hit the threshold where you would need to trigger that. And then as the time evolved, there was questions asked about some of the decisions that were baked into the triage protocol that had the veneer of science, but actually had some fairly potent effects on particular populations of, say, people with disabilities or other characteristics. Now, back after SARS-1 and in preparation for pandemic influenza, when colleagues and I from the Joint Center for Bioethics put together a report, we talked about the need to use the intra-pandemic period for decisions that were going to be highly contentious and operating on underdetermined and uncertain science, to have mechanisms in place for engagement with communities. And I think picking up on Alex's point, we missed that entirely in terms of policy making for low and middle income countries. And I've heard that loud and clear from my colleagues there. And similarly, we failed to engage. So it's an issue of epistemic justice. We're not including enough diverse voices that have a stake in this. Back to Alex's point, there is no COVID expert. If it's a pandemic, it's all people. And we should have invested, we should have taken very seriously the need for these types of processes to be put in place because we were told right, that this was going to happen. So it's a huge wasted opportunity. And all it's done is irritate and annoy people. Because now they feel like they're not listened to, they've been disadvantaged, they've been cut out, and people who are making decisions are doing their best under these exigent situations. So this has forced upon everyone a set of suboptimal decision-making conditions that was not necessary. So this is one thing I really want to point out. We created this problem for ourselves by neglecting the intelligence and thinking that was out there telling us to have something in place to mitigate, buffer, and manage this eventuality, which pretty much everybody in public health and epidemiology and infectious disease for the last 3 decades has said is coming. So that's something I think is really worth reflecting on.
I'm going to open it up to audience questions in a moment. So a reminder now in advance that if you have a question, the thing to do would be to post it in the Q&A box at the bottom of Zoom, and then we will, I'll direct them to the panel. Before I do that, I mean, we talked a bit about, it's come up now, this idea of the relationship between the public or the publics and scientists and other experts, and this issue of trust. So I wanted to turn to you, Maya. So you've thought about this issue quite a bit, especially in the context of vaccines. In fact, just this year, you have a new book out called Vaccine Hesitancy, Public Trust, Expertise, and the War on Science. So my question for you is getting to the specific example of resistance to public health measures. Even that's kind of a loaded term, but this kind of conflict or tension, sometimes cashed out in various examples, such as vaccine hesitancy. So, I mean, what are the sources, drivers of instances in which the public is reluctant or resistant or even outright refuses to follow recommendations made by what are considered to be public health experts? Is it a matter of trust, untrustworthy institutions, populism, a death of expertise? What's the right framing of the problem, and how should public health and the rest of us, all of us, respond?
As frustrating as some of the public resistance to various public health measures are, I understand them to be a demand for equity and justice. So I'm right away starting with a more charitable position on refusal around masks and things like that than the usual thinking, which the usual thinking is that these people don't understand science, they're stupid, or something along those lines. My research started around pediatric vaccine hesitancy, where there was a stronger case for that because there was a strong consensus on those vaccines. Why would anyone refuse vaccines that have a strong consensus? However, vaccines in particular, and I'm going to say now other public health measures too, are flashpoints for a number of issues. It's not just whether you want to wear a mask or not, whether you want to vaccinate your children or not, but also your perception of how that technology fits into the broader scheme of government, your life, your liberties. I could go on. So we see it strongly in social science research around vaccine uptake is people trust vaccines and will take up vaccines to the extent that they trust the system that brings them the vaccines. And that tells us that it's much more than whether you trust science. It's got more to do with whether you trust the institutional framework that includes science, of course, and has a lot of power over your life and your livelihood. So that's how I understand the issue. And I always move away from the conversations around what's wrong with these people, as if there's sort of an us-them thing. Instead, there's something in the circumstances of people's lives where they don't see as science as working to their benefit. They see science as, let's say, serving power interests, whether government or corporate interests, and they see the policies that come around it as not conducive to the lives that they want to live.
Alex.
I think a lot of those themes, Maya, extend beyond vaccines and then beyond the Western context as well. So similarly, when there is discussion about alternative medicine in the West tends to have the same tenor you're describing. And then when you transfer that kind of discussion to, say, traditional medicine in Africa, where it might, in some places, have been the only medicine available to many people for at least a large chunk of time, and might, where there isn't that much else available, it suddenly starts to take on a very different hue. So I just want to appreciate that starting point. It seems to me that much history of medicine and of public health also takes the view that people were just stupid when they thought that stuff worked and it didn't. And I think, that doesn't sit very easily with the way we talk about ourselves as humans, as problem-solving animals and acutely tuned to causal effects and this sort of thing. I mean, so I just want to stick up for that approach. I think that when you try and, that the particular reason that the context of things, of COVID, for example, and in general public health measures, is when you have things, and there's a question about whether it's a problem. So when you're not seeing it. And this goes back to the larger, the larger questions about very early stages in a pandemic. People are saying it's going to be bad, but it's not. And then also to countries where it just isn't that bad, and a confusion about why this is being prioritized.
Ross, I'm not sure if that's a hand up or just a pen. Okay.
Just fiddling with my pen.
Okay, so on that note, why don't I bring up a couple of questions that are coming up in the Q&A. So one of the early questions is the following. So how do we get public health officials to stick with communicating uncertainty and make their reliance on a certain ethical stance towards risk rather than falling back on the science says X and using a cudgel of false certainty to obtain public compliance? Ross.
So I think different public health officials are variably skilled in terms of their capacity to communicate uncertainty. And a lot of that has to do with how much training they get in their public health training. So I currently sit as a division head, and the largest public health preventive medicine program is in my jurisdiction, and they get a lot of training on health communications and uncertainty communications. The bigger problem is one in biomedicine. So we don't teach uncertainty at all. We train cadres of physicians and nurses and others in this view that uncertainty doesn't exist. It took me 15 years to get a lecture on uncertainty in the undergraduate medical education curriculum, and to talk about how uncertainty permeates virtually every aspect of medical decision-making and public health decision-making. And we ought to expect uncertainty rather than work from the standpoint of certainty. So I think if anything comes out of this and we go back and rethink how it is that we train our public health officials, how we support them, and I'm just going to put in a parenthetical advocacy point that if we continue to gut the budgets of public health departments globally, we're going to get what we asked for. I often ask my students, what's the budget for health in Ontario? And they'll underestimate it by about 500-fold. And then you ask them what the budget for the World Health Organization is, and they'll overestimate it by about 500-fold. So Ontario spends $65 billion a year on health, and only a portion of that goes to preventive medicine or to public health. And it's the first to be cut in any situation. The World Health biannual budget is about $2.5 billion. Some of our large academic health science centers have budgets that rival that of the World Health Organization. So if we're worried about the product that we get, that we don't have good risk communication, that our health professionals and leaders seem ill-prepared for this task, then we have to ask what we socially have invested in the process of ensuring that we have health leaders and health communicators that have the support and the skills and the ability to speak honestly, that they're protected, that they're not going to get fired if they say unpopular things, that they have functional independence, that medical officers aren't reporting to ministers, that they're reporting directly to the parliament, et cetera, et cetera, et cetera. So lots of things we can do to improve the idea of communications, and part of that is by training, supporting, and the people that are going to do that sort of work. Over.
Trish, you had your hand up.
I did, yeah. I wasn't sure whether I'd been speaking too much, so I kind of put it down again. I think this is a really interesting question, and I would say that I want to bring in Martha Nussbaum here. I don't know why. The whole business of why democracy needs the humanities. You remember that book? It's a bit old book now, but it's really important. You know, we need to make sure that our children and all our university undergraduates have some kind of exposure. This is to the humanities, because in a democracy, decisions are not all technical. They're not all rational in the narrow sense. It reminds me of a piece of work I did a few years ago about rationing in healthcare. So it's slightly off topic, but we had we sit and watch these local policymakers make decisions about who was allowed to have certain treatments, some of which are expensive. And people always began with the idea that if you had an evidence-based framework and you put the evidence into the top, turned the handle, out would pop the decision. And as we did more and more ethnography, we demonstrated that that's not the way these rational panels actually operated. What they actually did was they deliberated on the ethics, and they brought in all sorts of interesting issues, often personal experience, et cetera, and then they retrofitted that ethical decision to the evidence, and then they said it was evidence-based. Now, going back to the question, how can we get public health officials to share uncertainty rather than descend into scientism, if you like, an overinflated faith in rigid scientific principles? I think it's rather similar. I think we need to get people to be appropriately respectful of and skeptical of the tendency to descend into scientism, and actually also have more confidence in that deliberative process. And I think it's something we've slightly lost in this in the 21st century, and it needs to come back.
Can I just briefly add something there? There was a guy who became maligned basically because he was like a lockdown skeptic with a fantastic name. What was it? Lord Scrumptious or something. He was a judge. Somebody will come up with the name in the chat, I'm sure. But he said almost exactly that. He said that because he was asked, look, you're a lawyer, you're an ex-Supreme Court lawyer. Why are you commenting on this? And he said, well, we don't have to be scientists to apply our minds and critically form views, yes, somebody said Lord Jonathan Sumption, sumptuous is what I had in mind, Sumption. He was, he had a rough ride for saying that and was cast as a sort of right-wing iconoclast, but actually that's not fair, because what he's saying is actually, in line with what people like Philip Kitcher say. I mean, when they're talking about the place of science in a democracy, and I think that perhaps to step back, what this does show is that we're quite far from having a very comfortable relationship between science and democratic, at least, power, even among people who are well educated, and certainly not when it comes to much larger swathes of the population.
Thank you. Yeah, I'd like to go to another question that's been in the Q&A for a bit, and that's specifically around contact tracing. So the question is, what's the right philosophical framework in which to think about the failures of contact tracing in many liberal democracies? And I see, Ross, you were eager to answer that question. Do you want to give us your thoughts?
I sort of answered it by saying if you cut public health, you're going to find you're not able to contact trace. And so, we've had this experience twice in Ontario, and I knew we were in deep trouble in this particular pandemic when the largest metropolitan area in Canada said that they were going to stop contact tracing. That meant that's when you have uncontrolled transmission. But we never got to the bottom of why that decision was made. And it's straight out funding. If you look at the number of people who work in, so the same people who are supposed to be doing all of the other, that, it's not just that the pandemic is happening, there's still STIs, there's still tuberculosis, there's still opioid overdoses, there's still a large burden of public health issues that require the attention of public health. And if you've cut them to the bone, as we've seen so many times, then they're not able to respond. So the correct philosophy is, I would say, put it in a communitarian perspective, is one that views and values community health and well-being to the same extent that it values this notion of liberty. So we end up with these false dichotomies of, personal liberty versus community well-being. If we look at most constitutional democracies, they have public health law in place with provisions to curtail individual liberties for the purpose of controlling community health spread. Interestingly, my youngest daughter is in Seoul, Korea, studying, where she has a lot, I think they have a little bit less resistance to being tracked, followed, and traced. And they've had this pandemic under relatively good control compared to other places throughout the time. So it's, again, back to our concepts of democracies, because there's different ways in which it's shaped and formed, and the extent to which we put community health as a value, and how we marshal, mobilize, and invest resources to that end, and not see it as an opposition or enemy to our freedom and well-being, because if everybody's not well, no one is well.
Go ahead, Sang-Wook.
Yeah, I think there's I mean, as Lo said, that every institutional society has a certain restriction over the public, the individual liberty when there is a need for the general good or public health consideration. But I just want to point out that the way of achieving this public good may vary from one country to another country, depending on the historical context and the cultural heritage. For instance, South Korea, although, as Ross pointed out, that we are more responsive, more readily acceptable to the contact following system, we are very strongly opposed to the lockdown. So we were actually quite surprised that many European countries where the citizens are very sensitive to the liberty issues are responsive to the lockdown issues, because it has related to our historical heritage. I mean, in our authoritarian government in 1970s, we have the nighttime knockdown from 12 to 6 for like 20 years, maybe less than 20 years. But so, well, lockdown for us signifies this authoritarian government regime. So we are very, very strongly opposed to this lockdown policy. So that's why South Korean government couldn't bring this lockdown policy in South Korea. They did it very small area like Daegu for like 1 month, but even that policy was strongly opposed by many Korean people. So this restricting individual liberty issues is very sensitive, as you said. But I think what is the reasonable policy, the decision about this reasonable policy may depend on the history and cultural as well as other consideration.
Alex.
Yeah, to follow on from that, I mean, I think that's right. Another factor is how people respond. So, for example, Sweden had relatively lenient policies, but it has a very high level of compliance in general, as does Korea. You know, in London, even within the UK, I suspect that, you know, I grew up in London, I suspect and have observed that general compliance with street level rules is lower than it might be in other parts of the UK, and then, you know, and so forth. And I think that those factors are probably as important as what is actually, you know, and then again, obviously, as I say, in South Africa, I mean, they put in place a lockdown, which in large parts of the country just wasn't observed, one suspects, and there's good evidence for that as well. So I think that that's absolutely right. There are these, there's what will be acceptable, and then there's what people will actually do in response to a regulation, and that can vary enormously, and that can have a very significant effect.
All right, why don't I move on to another question? So getting to this topic of traditional medicine and traditional perspectives, somebody was asking, Ben was asking, shouldn't we be rolling out plant-based cures if we're really going to take traditional medicine seriously, such as that developed in Madagascar? If not, aren't we just paying alternative medicine lip service? So why, or what does it mean to really take traditional medicine, and maybe I'll broaden that traditional perspective seriously in response to COVID-19?
I mean, I have a stance on this in my book on medicine in general, which is that it doesn't mean relativism. So it doesn't mean you just say, oh, anything goes, whatever works, works. What it means is you try to you take seriously the possibility that something works, but you then do not, you know, you have an epistemically humble attitude towards it. You try and assess it reasonably, and you don't dismiss things out of hand. You don't poo-poo things, but you don't then come to the conclusion that therefore. So, I mean, maybe to take the vaccination example, if you wouldn't then conclude, oh, well, it's okay to not take a vaccine if you kind of don't come from that community. And it's just that you start from this epistemic position that you're not dealing with an idiot or with an idiot society or anything like that. And you also start with the view that it's possible that because medical matters often are highly uncertain, medical knowledge is not actually that well advanced in relation to the, you know, the complexity of the human body, or the mysteries of disease and a sort of grand scale, and has a long history of error. You start with this view that there might actually be something to learn. So I would say yes. I mean, one should be testing things that have some plausibility, if they have some plausibility of working. And then if you're dealing with communities or with people who are on the totally wrong track, as far as it seems from a kind of a scientific viewpoint, then the correct approach is not, as I say, to cast them as idiots. The correct approach is to try and engage with them. That also, I suppose, builds trust of the right kind.
Over to you, Maya.
It's also worth remembering that the kind of resistance that is the reason that sometimes people gravitate toward alternative medicine, at least in the global north, is because they've had bad experiences with biomedicine. So alternative medicine in Canada is almost entirely used by women, and many of those women will talk about bad healthcare experiences. So that's worth noting, that there's a reason that people gravitate towards. In the global south, it might be due to lack of access, but also mistrust of Western medicine as representative of colonial or imperialist powers that can be nefarious. So we don't want to start the conversation focused entirely on, well, then should we just use stuff that doesn't work? Because that assumes too much about why people are are looking to that in the first place. Also, there is a lot of opportunity here to try to create those kind of complementary practices where people can engage with biomedical technologies and use traditional medicine or traditional technologies in a way that it doesn't have that sort of ideological schism where you have to pick one or the other, but the two can actually be compatible. That's how I think we should be thinking about traditional practices around COVID and other things.
Ross.
Yeah, my simple suggestion, so if we're moving to these large global platform adaptive trials that each system have an indigenous or arm, put them in, see if, that meets Alex's condition of reasonable presumption of effect, and you can rapidly compare them with any other trial. There was a lot of studies of Chinese traditional medicine in early in Wuhan. Most of the studies were very small, so there was no power to actually detect whether there is a difference. If you look at the trials registry, and there's no reason why they shouldn't have access to these sort of epistemic engines. But it's really interesting when I actually asked this at a WHO meeting, why don't you have an arm in these global adaptive platform trials to try out traditional or alternative therapies on that presumption of let's figure out whether things work, rather than the uncontrolled application of them under unregulated and unmonitored circumstances.
Thanks. We had another question that I wanted to get to. We have a few minutes left. And this was back to this issue of deliberation in society. So the question is, to what extent is the liberal notion of ideal speech or deliberation realizable in a situation where powerful interests, often private commercial, can hold sway over discourse? Anybody want to be bold enough to try their hand at this one?
I can have a go. I mean, I don't think there is any situation in which that ideal is realized, because one's always engaging in a conversation with some people, and there's always some social dynamics at play and some power dynamics at play, and there are always some things that can be said and can't be said. And one is always thinking about the consequences, and that's just, so I think that in some sense, the ideal itself is not correct. I do think you can set up structures which permit a kind of discussion that have good epistemic qualities, and I mean, obviously in a legal context, that's very well established. And then the question is whether those contexts, so to take the legal situation, like a litigation situation, the question in law of evidence is whether the contexts actually do get you to where you want to be epistemically. It's very interesting that that there isn't such in science. There isn't anything equivalent to the law of evidence, and I'm not sure if there should be or not, really. I mean, it's almost, one of the most, again, a frustrating thing about the pandemic has been to see people calling each other scientific and unscientific, despite the fact that, in 200 years since the idea of a scientific method was sort of proposed, nobody's been able to say what it is. I think, in short, there's going to be powerful interests, but you can set up structures that allow for reasonable debates, that curtail disagreements, that enable different perspectives to be given airtime, that make shouting down harder, that protect people from their from consequences to some limited degree, which enables people to say things that they might not otherwise be able to say. So I do think that you can do that, even though there are powerful interests at stake. Yeah.
Sang-Wook, go ahead.
Yeah, because this question is too difficult to answer in a satisfactory way, I just try to give you very obvious and relatively less controversial partial answer, which is this. Alex mentioned the Philip Kitcher's book on the science in a democratic society. What I really liked in that book is Kitcher's emphasis on the condition of harmony of evidence. So it's very difficult to have an ideal public deliberation on these very difficult issues on public health and pandemic. But even before we actually require this ideal deliberation to be satisfactorily done, we have to provide the basis for this public participation in the way that all the good evidence we can gather from the different disciplines should be provided fairly and symmetrically to the people who are going to discuss and try to find out the solution or final decision. And this condition of harmony condition should be met in order to have a good public deliberation.
Thank you. And on that note, unfortunately, we're out of time. So I'm going to have to thank all of our panelists sincerely for joining us. Thanks to all of you for listening. And let's keep the conversation going in various channels.